Good evening, everyone. On behalf of Merck India, I'm Juhi Gupta from the marketing team, and it's my pleasure to welcome you all to yet another session of our MedChat series, which encompasses topics around METex14 skipping NSCLC. Today, we are truly honored to have a distinguished panel of experts and our international faculty with us today. A special thank you to Professor Frank Reisinger, who has joined us from Portugal and to just share his invaluable insights today. I would also like to extend my gratitude to Dr. Shekhar Patil sir for graciously agreeing to chair today's session. We have a well curated agenda for you today. Can we move back to the agenda slide? Yes. And we'll start by Dr. Shekhar Patil sir giving welcome and context setting. Then Dr. Rajat Bajaj sir will be taking us through epidemiology insights into NSCLC rare mutations in India. Then we'll listen Professor Dr. Frank Reisinger around overcoming the challenges in Metexon 14 skipping NSCLC. Then Dr. Ajay Kumar Singh sir will be sharing us few of his case studies around his experience with MET inhibitors, including TETMETCO. Followed by that, we'll have our panel discussion, which will be moderated by none other than Dr. T. Rajas sir. And in our panelist, we are delighted to say that we'll have Professor Dr. Frank Reisinger, Dr. Rajat Bajaj sir, Dr. Ajay Kumar Singh sir, Dr. Deepak Gupta sir, Dr. Priya Tiwari ma'am, and Dr. Ravi Jaiswal sir. And then we'll have our final concluding remarks at the end of the session. So before dealing any further, I would like to introduce to the entire group Dr. Shekhar Patil. So actually, he needs no introduction here. But yeah, can we move to the next? Yeah. So Dr. Shekhar Patil sir is a highly respected senior consultant in the medical oncology at the HCG Cancer Center in Bangalore. And he has 32 years of experience in oncology and internal medicine. He's also earned his medical degrees from MR Medical College, Gulbarga, and he's completed his DM in medical oncology at the Esteem Adyar Cancer Institute, Chennai. His clinical expertise spans around lung, breast, and gastrointestinal cancer. And also, Doctor has served as a principal investigator in numerous national and multinational clinical trials, and his research has been widely published with over 30 papers and presentations, including at ASCO. He not only that, but he is a committed public health advocate, and he has led more than 100 cancer detection camps in rural parts of Karnataka. And he's also a member of several prominent oncology organization and continues to blend clinical excellence and research and community outreach to elevate cancer care standards across India. So it's an honor to have you with us today. Over to you, Dr. Shekhar Patil, sir.
Yeah, thank you, doctor, and thanks for the kind words. And first of all, thank the Merck for having given me this opportunity to be a part of this interesting program. As we all know that lung cancer, particularly the non-small cell lung cancer, and that is the adenocarcinomas, which constitute around 80% of the non-small cell lung cancers. We see a lot of more than 50% of the patients have got some actionable one or the other mutations, or you may have a PDL1 where immunotherapy can be beneficial. So slowly in lung cancer, we are moving away from the standard chemotherapy, combination chemotherapy, what we were practicing years back. There may be a combination of chemotherapy with other targeted therapy or immunotherapy, but chemotherapy alone may not be a very good option in majority of the NSCLCs as we see. This all thing has happened because of our better understanding of the biology of the cancer and better identifying the biomarkers from the tissue and also from the liquid biopsies. We are identifying a lot of, initially we were very comfortable looking only for EGFR mutation or ALK mutation or ROS1 mutation. That used to be our last stop for looking for some actionable mutation. Now we have got so many biomarkers and actionable targets for which drugs are available. In that direction, the MET mutation is found to be very useful because it is one of the resistant mechanisms for most of the EGFR and ALK related EGFR treatments, resistant mechanism. But this MET exon skip mutation can be a direct exon, direct mutations, which biomarker which is present on the cancer cells. And we have got extremely good drug available for this MET exon skip mutations now with lot of TKIs available. And chemotherapy is not that very effective alone in the MET exon skip mutation. If at all you use chemotherapy, it has to be in combination with immunotherapy. And that too, with the present available TKIs, I think the chemo plus immunotherapy, if at all we use, it may be only in patients who don't respond to the chemotherapy, they respond to the TKIs, or they are intolerant to the TKIs. So that is the situation where we are there today in terms of the MET exon skip mutation. Even though it may not be a very common mutation, around 2 to 3% of our patients we do see showing this MET exon skip mutation even in our Indian context. Can I have the next slide, please? Next slide, please.
Team, please go to the next slide. Nirav? Yeah, thanks.
So, so the basic objective of today's meeting is to know how common is MET skip mutation in non-small cell lung cancer in the global arena, and also in the Indian context, how common it is. What are all the drugs available for MET exon skip mutations? What are the mechanism of resistance, even if they respond to the treatment? And to understand major problem with this TKIs is the associated adverse reactions which we are seeing with these drugs. So how to mitigate this adverse reaction, how to modify the dose. These are all the things which we have to learn as we go on. So today's meeting will be very interesting because we have got a very interesting speakers, particularly from the Indian context. We have got doctors who are going to give us the Indian experience, and we have got an international speaker. So it will be very interesting to see the meeting moving forward in the next hour or so. We will be learning everything about how to identify the MET exon skip mutation, and which type of tests should be used, and how to select out the treatment, and how to overcome the adverse reactions which are going to occur in the usage of these drugs. So that is the objective of today's meeting, and I will hand over to the organizers for continuing with the further talks. Thank you. Thank you very much.
Thank you, Dr. Shekhar Patil, sir, for your kind words and introduction around this particular topic. Now we'll move forward with the next part of the session, which is Epidemiology Insights into NSCLC and Rare Mutations in India by Dr. Rajat Bajaj, sir. So Dr. Rajat Bajaj, he is a senior consultant in the Medical Oncology Department at Fortis Hospital, Noida. We welcome you, sir, and over to you.
Dr. Rajat, if you can unmute yourself, sir.
Dr. Bajaj, are you there?
Maybe some technical glitch. Allow us a minute to solve this. I'll just request everybody to just wait for a minute or so that we can solve this technical glitch.
Doctor is trying to rejoin, so maybe request all the faculties to be patient for a minute. Thank you. So till the time Dr. Rajat joins, so Dr. Grisinger, if
Rajesh.
we may ask you, Professor, in your practice, how much is the our METex14 skipping mutation do you observe in your clinical practice?
So Dr. Bajaj has joined.
Yeah, Dr. Rajat, can you hear us, sir?
Yes, I can.
Yeah.
Am I audible?
Yeah, you are audible, sir. The voice is little trembling, but yeah, you are audible.
Is it better now?
Yeah, much better,
Yes.
sir. Please go ahead. Thank you.
Yeah. Good evening, everyone. Uh, Good evening to Professor and all the other audience who are there. And I thank Merck for organizing this CME this evening and having me here. I've been told to talk about the topic of epidemiological insights into the non-small cell lung cancer and the rare mutations in India. Next slide, please. At the outset, I would say that this is a very important topic that we are going to discuss. The MET amplification and the exon 14 skipping mutation in MET is, I think, a rare entity which is often missed in some of the NGS that we do. But then we all know that this is an important entity, and we have had all have had patients who have had this, and with the targeted therapies that we have now, especially TEP-METCO, I think patients have benefited a lot. So this is something that is a very important concern that we have, that this should be more and more tested. And if patients come out to be positive, we shouldn't shy away from using this therapy in the benefit of the patients. Nevertheless, this is the disease burden of cancer in India. We all know that lung cancer is one of the common cancers that we see in our daily practice, and this is elucidated very well in the Globocon 2022 data that we have on the screen right now, where we see that over 24 lakh new cases incidence wise was seen for lung cancer, and the deaths were about 18% of them with lung cancer. If we talk about the Indian scenario, it's also resonates with what was in the scenario across the world, that over 80,000 patients of lung cancer, new patients were seen, and out of which 8% deaths were with lung cancer. What it amounts to is that India is the fourth highest contributor to lung cancer incidence worldwide. and lung cancer accounts for 8% of all cancer in males and 3% in females, and lung cancer is the second and the seventh most common cancer in males and females respectively. Next slide, please. Now, if we talk about the burden of cancers in India and the estimate of cancer crude incidence according to the various parameters that we have, we see that the changes in the DALI index per 1 lakh of cancer site from 2004 to 2021, they tell us that there was a time when lung cancer was not the most important or the most prominent cancer we had in our country, but then things have changed in the last 2 decades or so, where we see that lung cancer is right there at the top. And if we talk about both male and female gender combined, there also after breast cancer, lung cancer is there. So there's no doubt that it's a preponderant disease. There's no doubt that the mortality is still high despite all measures, and we have to find more ways to improve the mortality in such patients. Next slide. Now, talking about, next slide, the oncogenic driver mutations that we all know in lung cancer for the last maybe 2 decades or so. It all started in the end of 1990s and then carried on to the early 2000s, where we were trying to identify the oncogenic driver mutations which actually drive these malignancies of lung cancer. And we found out that are different drivers for different histologies, for adenocarcinomas and squamous cell carcinomas. This is right there on the screen. On the left hand side, if we see that in adenocarcinomas, there are more mutations that we find out. These patients are mostly patients who are females, they are non-smokers, and one can see that about 25% of these are going to be KRAS mutations, 16% are EGFR, and then we can have rest of the other mutations ranging from 2 to 10%, be it the BRAF or the MET mutations or the ALK, the ROS1, the NTRK, the RET or the HER2. But if we talk about squamous, then the squamous patients are not that fortunate to have the various targets. And if we talk about the squamous, about more than 50% would have only a wild type a process as far as the mutations are concerned. And if at all they have the mutations, they are either not very good mutations, I would say. So either they have FGFR or PIK3 or PTEN in that regard. But if they have patients who are non-smokers and they are squamous histology, they are still amenable to have mutations. So these are the patients who should be tested, and this is category 1 recommendation even by NCCN. Next slide, please. There is no doubt that with the data which is accumulated in the last 15 to 20 years, more are the chances of survival if a patient has got an oncogenic driver mutation positive. Patients are living up to 7 to 8 years, and that is what we keep telling our patients in our daily OPDs as well. Can I have the next slide, please? Now, this is what the evolution of lung cancer treatment has been as far as the molecular targeted therapies has been concerned. There was a time when we used to tell that the lung cancer is only histology driven, but here you can see that in the slide which has been shown on the right hand side, that patients can have not only histology based classification for lung cancer, we have a huge host of molecular testing which is available, which are just enumerated, and we have a lot of options as far as the targeted therapies and oral tablets are concerned, and all of them are enumerated next to the mutations which are present in the screen right now. Next slide. Now, if we talk about the actionable biomarkers which the patient has, and these are the first line treatments. So it is very clear that NSCLC patients, they do use these targeted therapies and are facilitated to improve their outcomes. This is also a category 1 recommendation by all the guidelines, including NCCN. And this is a bar diagram which tells us that a proportion of patients with metastatic NSCLC in a US cohort who received biomarker tests either before or during first line of treatment, when one can see that prior to first line, there were much more number of patients compared to patients who were during or no biomarker test which was done, which means that if this particular data set which spans for over 3000 patients tells us, this is very clear that there is an acceptability across the globe as far as the oncologists are concerned, that this is how the process should be and the patients should be subjected to the testing of these driver mutations in the very beginning. Next slide. Now, is NGS the right answer for Indian NSCLC patients? So probably the answer is yes and a bit of no. If we talk about the sequential testing of individual genes compared to NGS, upfront NGS has definitely resulted in an additional mutation finding in patients, and that to actionable alterations. The turnaround time for NGS is bit of a concern, and it is approximately 2 weeks, and the cost increment also is there, which somehow has been taken care of by a multitude of options which have come now for NGS, but then still is higher than what the individual genes would actually tell us. But very importantly, if we talk about the complex EGFR alterations, variants of ALK fusions, especially the RNA fusions like ALK and the ROS fusions, there the individual genes would actually take a beating and the NGS would prevail much more, and the percentage found or the quantum of benefit ranges from say about 1 to 5 to 10% as well. Also, in patients who have squamous histology, especially exon 14 skipping mutation or a KRAS G12C is found more if you're using NGS. So probably the answer is that NGS, barring 1 or 2 negative points, especially about the turnaround time, I would say, is always scoring more as compared to the individual genes testing. Next slide. This is a comprehensive molecular analysis of driver mutations in NSCLC. This is Indian perspective, and one can see that if you talk about the this paper, which is from 2024 by Dr. Agarwal et al., out of 550 odd patients, approximately 60% of the patients had either one gene alteration or more, be it EGFR, ROS, BRAF, MET, or ALK. MET and BRAF mutations were much more common in the elderly population, and in the younger population, it was EGFR, ALK, and ROS1. Next slide, please. Continuing with the genomic landscape of this lung cancer in India using the circulating tumor cell DNA, here also we find that EGFR is right there at the top, which is more than 25%, followed by HER2 and then KRAS and MET in that order. ALK is somewhere around 1.8%. So this is according to ctDNA. It may not be reflective of actual figure which is there once we're talking about the solid the solid tissue biopsy and then leading to an NGS, but this is what the figure comes out when we're talking about a ctDNA profile. Next slide. So talking about the summary, India is the 4th highest contributor to lung cancer incidence globally after China, US, and Japan. Molecular testing assists in the selection of targeted therapies. NSCLC biomarkers can be tested via tissue or liquid biopsy both. And recent Indian studies have adequately documented that the prevalence of tumor mutations in Indian NSCLC patients is way higher as what it is in the Western population, and more studies on larger number of patients can be done. Next slide. Yeah, with this, I thank you all for your patient listening, and back to the organ.
Thank you, Dr. Rajat, for giving the Indian perspective on the MET exon skip mutation. Now we'll move on to the main talk by Professor Frank Grisinger. And Professor Grisinger is a professor of internal medicine and a director of clinic for hemato-oncology at the University of Oldenburg. And Professor Grisinger is a leading author in thoracic oncology, and his main focus is on the lung cancer research, molecular diagnostic, and precision medicine. And he has been authored more than 150 peer-reviewed publications, and he is involved in the various national and international guidelines in the lung cancer arena. He is a leading author of the Oncopedia Lung Cancer Guidelines, and he represents the DGHO in the German Cancer Society's guideline program. His clinical expertise spans both in the non-small cell and the small cell lung cancer arena, and his leadership roles in the pivotal studies such as the CRISP study, the PACE lung study, and the Trident 3 studies is well known. He trained at the universities of Frankfurt and completed his fellowship in molecular and cellular biology at the University of Minnesota. Professor Grisinger has been honored with the Theodore French's Prize, AIO Innovation Prize, and several poster awards from the DGHO and the NSCLC, recognizing his impact on advancing the oncological research and patient care. This is in short the introduction of Professor Grisinger, and it is over to you, sir, for your talk. Thank you very much.
So thank you very much for these very kind words regarding my my person. I will just share my slides now. Right, this should be it. So, let's see. Okay, so the title of my talk is Overcoming Challenges in METex14 Skipping Mutated NSCLC. I just have to make sure that I see the whole slide right. Okay, and again, thank you very much for inviting me to give this talk. I have like 50 slides now, and I hope that I will be done in about 25 minutes. I was told that if it's 30 minutes, then it's okay also, but I try to keep my time. So first of all, MET receptor belongs to a superfamily of receptor tyrosine kinases. As always, if you have a membrane-bound receptor tyrosine kinase, then you have an extracellular domain which normally binds HGF, and you have intracellular domains and a juxta membrane domain, which I will come back on in a minute, and of course the kinases, and it activates downstream pathways, and it plays a key role in tissue regeneration, wound healing, and embryonic development. On the right side, you see the receptor. Now, MET dysregulation in cancer can occur either with MET amplification, and I will not talk about MET amplification today. This is a rather difficult target. There's a lot of data occurring, but how MET amplification really can be measured is kind of a matter of debate. And MET exon 14 splice site mutations, of course, are really genuine oncogenic drivers. So I'm talking about this one now. Now normal splicing results in the excision of the introns and the fusion of the exons. So exon 13 fuses to exon 14, fuses to exon 15. And then you have exon 13 to 15, which is normal splicing. And if you have a splice mutation, then this mutation always occurs in the intron and makes splicing, the regular splicing, the normal splicing, impossible, therefore leading to the fact that exon 14 is skipped. And then you have the fusion of exon 13 and exon 15. And as you can imagine, you can either detect by NGS the intronic mutations that lead to this exon 14 skipping, or you can also do it with a RNA, like an Archer amplification, and just look exactly at the RNA, whether there's a splice variant of the MET gene. Now, what happens if you have MET exon 14 splicing mutations? Then you have the loss of the juxta membrane domain, this domain is a negative regulator of MET and also leads to ubiquinylation of the MET receptor. And therefore, if you have this splice variant, then you get kind of an amplification by an increased stability of MET, and you also get an increase of the kinase activity. Now, how frequently does this occur? And this occurs in about 3 to 4% of the patients worldwide with non-small cell lung cancer. And it has been alluded to already. Molecular testing, of course, is paramount. And if you don't test, then you don't identify those patients. Here again, another overview of the incidence is given here, METex14 skipping with 3%. And what is also important is that the clinical characteristics of these patients is different from the patient that you normally would associate with oncogenic drivers. And therefore, EGFR, for example, is compared now to METex14 skipping. And you can see that these patients are older. These patients have smoked, not as much as KRAS mutated patients, but much, much more than EGFR and also ALK positive patients. And these mutations or METex14 skipping mutation is not only reserved to adenocarcinomas, which is mostly the case for EGFR and also KRAS, but also for pleomorphic pleomorphic carcinomas and also poorly differentiated carcinomas, and also to adenosquamous carcinoma. So there's a little bit of a difference in the patient characteristics and also in the histology of METex14 skipping mutations. Now I go over this very quickly. NCCN recommends testing for METex14 skipping in the first line, or prior actually to starting first line. Also the ESMO guidelines, you have the frames there on the right-hand side, also recommend testing and the use of either platinum doublet or a first-line capmatinib or tepotinib therapy. And also Thoracic Oncology Research Group also recommends testing for METex14 skipping. So basically all the guidelines, including also the German guidelines with Oncopedia and S3 guidelines, also recommend testing in the beginning, so prior to starting first line. So what's the standard of care and how do the results of the standard of care, which is chemo or chemo-IO, compared to TKI, so tepotinib treatment? And as you can see here on the left-hand side, you see here patients that had chemotherapy. This is the kind of orange line, and you have the patients with MET inhibitor. This is very early work, and there you can see that the OS, the median OS, is increased by factor 3. So basically, if you treat these patients with chemotherapy, then these patients have a much, much inferior outcome than if you treat these patients with a TKI. Now, also, the question is always, if there's high PD-L1 expression in the context of a driver mutation, can we just start with a PD-L1 inhibitor? And you can see here that METex14 skipping have kind of an intermediate tumor mutational burden. But if you treat them with immunotherapy, then the median PFS is very, very low. This differs from KRAS and especially BRAF non-V600Es, and also the BRAF V600Es, which are highly or much, much higher immunogenic and where immune therapy can be given. Here's the median PFS and the median OS, again plotted for IO. And as you can see, a median PFS with MET inhibitors is 15 months, with MET inhibitors is 30 months for OS and 15 months for PFS. So clearly a PD-1 or PD-L1 inhibitor is not a good choice for patients with METex14 skipping mutations. This is a pooled analysis with more patients where they treated those patients with IO monotherapy or IO CT. And as you can see here, the PFS, this is real-world PFS, is higher for TKI, and this also is true for IO plus chemotherapy. This is PFS. Now comes OS, and also here the TKI, so MET inhibitors are better in terms of real-world OS, both compared to IO monotherapy and also IO chemotherapy. So definitely NCCN guidelines and ESMO guidelines recommend treatment of METex14 skipping mutated non-small cell lung cancer with TKIs, and especially with tepotinib and capmatinib. And I can tell you that in Germany, capmatinib has been retracted from the German market. So we only have actually accessible for our patients tepotinib. So why are these recommendations been made? Of course, you need a study, and this study is the VISION study. And this is the largest study with more than 300 patients with METex14 skipping. It was one of the first clinical trials. One thing is really stands out is that elderly patients were included in this trial, and I give you the median age of these patients in a minute. And the trial was line agnostic, so both treatment naive and also pre-treated patients could be included. And there were also patients with brain metastases. 18% of these patients had brain metastases included in these trials. Now, the VISION study had a cohort A, which was the primary analysis, and then a cohort C with a confirmatory analysis. And you have a total of 313 patients that actually were included, of which 164 were treatment naive and 149 were previously treated. Primary endpoints are shown in the bottom. And as I promised you, the median age of these patients is pretty high. I mean, normally you have a median age in studies that is around 60 to 62. And here it's 74. And for the previously treated patients, a little bit more than 70 years. Most of the patients were adenocarcinomas, and as I told you already, brain metastases at baseline were allowed and were close to 20% of the patients. Now, there's one peculiar thing about the VISION study, which actually led to the inclusion of a lot of patients also in my center. And this was that not only tissue, but also liquid biopsy was allowed for inclusion of the patients. So the biopsy method was done in, method was done in for tissue in 208 and liquid 178. So of course, there are some patients that were included based on two analyses methods. And it seems that there's a difference between the patients that were only diagnosed by tissue and the patients that were diagnosed by liquid, in that the tumor load of the target lesions was higher in the patients with liquid. And one can imagine that of course, you have more ctDNA that gets into the blood if you have more tumor load, and if you have less tumor load, then sometimes liquid biopsy is not sensitive enough, and therefore you cannot detect those patients. This is also reflected by the fact that more than or equal 3 target lesions was less pronounced in the tissue alone patients, and 36% had more than or equal 3 non-target lesions. And here you see that the numbers are much, much higher. And also the incidence of brain metastases was higher in the liquid versus the tissue alone biopsy patients. Now, this gives you the objective response rate, which was the primary endpoint of the study. And you can see that it's a little bit higher in the liquid biopsy, but the median duration of response, the PFS and the OS is somewhat higher in the tissue alone patients. And also there's a tendency that the first line patients fare a little bit better than the second line patients. This is again the 3-year vision data efficacy of the cohorts taken together. This is the duration of response, right? This is the first line patients. This is the second line patients. So the first line is a bit better. PFS better, 12.6 versus 11.0 months. And also the OS, there's a tendency for the first line patients to have a higher benefit than the second line patients. But overall, if you look at OS, I think the fact that a good TKI in a good oncogenic driver results in a similar OS in first and second line therapy speaks to the efficacy of this TKI. Now, this again is the responses according to the biopsy method. Tissue and liquid, 111 patients, 95 patients. The objective response rate was pretty much the same. The median duration of response was very high in the tissue alone with 46 months versus 19.4 months. The median PFS 15.9, 10.3, and the median OS 29 versus 17.6. And this is the treatment-naive patient outcomes, objective response rate 60%, median duration 46, median PFS 50.9, median OS 29.7 months. So again, and more than about 90% of the patients experience a tumor shrinkage with tepotinib. And if there was shrinkage, then this shrinkage really lasted for a long period of time. This is the patients that were previously treated. So here also very high objective response rates, a little bit lower median duration of response, median PFS, and median OS. But these tumors were still sensitive to the TKI. And well, of course, it's relevant for you because you're in Asia. How do the Asian patients fare? And the treatment-naive patients had an even higher objective response rate with 64, median duration of response 27, median PFS 16.5, median OS 32.7 months. So a tendency of being a little bit higher than the overall population. And this is the previously treated patient population, also pretty much inconsistent with the overall patient population. Now, one thing is, of course, always very relevant, and this is the efficacy in brain metastases. And here you can see that on this column, you have patients with brain mets, 57 patients. And here you have the patients without brain mets, 256 patients, and the objective response rate was pretty high. As one would expect, patients with brain mets have a worse outcome. So all these numbers here with median duration, median PFS, and also median OS are a little bit lower than the patient without brain metastases, but there's a high efficacy of tepotinib for brain mets. This is also reflected by the RANO intracranial efficacy with an objective response rate of 66.7%. And you can see on the right-hand side, 66, 10 of 15, treatment naive, 6 of 10, so 60%, previously treated 80%. I mean, this is very small numbers, but speaks to the efficacy also in the brain of tepotinib. This reflects again whether there's any patient population that kind of sticks out that might benefit more or maybe less from tepotinib, and you can see here that the objective response was pretty much consistent irrespective of age, and we have very old patients in this cohort, sex, smoking history, and ECOG PS. And this is also reflected here with the median duration of response. No difference in sex. We always thought that maybe their smoking would confer a inferior outcome, but this doesn't really seem to be the case. The curves are pretty much the same. So this is a little bit different to the EGFR story, because there are some very nice data suggesting that EGFR mutated patients that are smoking or that have been smoking, or heavy smokers, have a worse outcome. This doesn't seem to be the case for METex14 skipping. Also, age cutoff was 75 years, didn't have any impact, and ECOG PS 0 versus 1 did not have an impact. Now, you have, as far as I know, in India also available capmatinib. So it's of course interesting, as there's no head-to-head comparison, to see whether there's any matching adjusted indirect comparison. Yes, there are. And the vision trial and the geometry trial was compared. And I just show you the curves, and the blue curve. I think it can be seen. I hope rather good. This is the capmatinib curve. These are the two tepotinib curves with weighted and unweighted. And there's, I mean, there's consistent result that at least tepotinib is not worse than capmatinib. If anything, it's better. And this also holds true for the OS, where tepotinib is slightly better than capmatinib. This was the treatment-naive patients, and this holds especially true in the treatment previously treated patients, where you can, of course, see that there's a big difference between tepotinib and capmatinib. I'm not really sure whether this is really a difference in efficacy, or whether this was just a question of how the patients were selected. But as you can appreciate here, tepotinib has much better results than capmatinib in this indirect comparison. And also the side effects seem to be rather in line with crizotinib than with capmatinib. So capmatinib was associated with a little bit of higher toxicities than tepotinib. Now, coming to the side effects, and basically there's only one side effect that really is very serious, and this is peripheral edema. The most common treatment-related AE, peripheral edema, was reported in 50 to 63% of the patients across the clinical trials. Nausea was reported in 26% to 46% of the patients, but at least in my opinion, it doesn't really play a big role. There's also some liver enzyme increases, which normally are transient, and you don't really have to, in most of the cases, you not even have to reduce the dose. There's some other less frequent side effects, which is ILD and hypoalbuminemia, and also increased creatinine. And I will go on the peripheral edema and also the creatinine. I've prepared some slides for that. So there's a class effect of MET inhibitors in terms of edema. It is frequent with MET inhibition. The mechanisms is not really very clear, but there might be some inhibition of vascular and lymphatic endothelial tissue mechanisms. And the onset differs. Tepotinib edemas normally come within about 8 weeks. With capmatinib, sometimes it takes a little bit little bit longer, but I'm not really sure whether this is consistent, right? And again, the risk of edema, of course, increases with age, and the older patients you have, the more risk of edema, irrespective of TKI treatment you have. So you have to take this into account as well. So what do you do against for the prevention of edema? For risk factors for edema includes age, high body mass index, low mobility, and also the duration of treatment. There might be some cardiac diseases that are also underlying that should be diagnosed and also treated adequately. What I always recommend my patients is increased physical activity, elevating limbs, using compression stockings, and not when the edemas occur, but prophylactically when you start the treatment. We've also learned that lymph massage can also be very beneficial to those patients. Reducing salt intake or non-pharmacological measures can also be used. The preventive measures can be seen here on the right-hand side. And I think that a lot of physicians actually do multiple methods at the same time, as I also told you what I recommend to my patients. And I think the most important thing is elevation limbs, using compression stockings right when you start with the therapy, and also lymph massage. Monitoring, of course, is important. Even peripheral edema with toxicity grade of 1 negatively impact quality of life. Not only 2 and 3s are negatively impacting quality of life. So regularly monitoring should be done, and special attention to elderly patients. I think the conservative measures I've already alluded to, and of course, TIP-METCO should be interrupted in a patient with grade 3. I probably would not wait until grade 3. I probably would interrupt or dose reduce even earlier, because once you have the edemas, it's really very difficult to treat them. The other thing is creatinine increase. Normally, it's not really having any symptoms, and it's probably just kind of a lab toxicity. It's the mechanism is a little bit unclear, but tepotinib seems to inhibit renal tubular transporter proteins OCT2 and MATE1 and 2. So management would be also naturally monitoring, and if you think that the creatinine goes up too high, then of course one can also do dose modification or interruption. But renal function estimates should be interpreted with caution, considering the effect of tepotinib on transport proteins. So normally TIP-METO is pretty well tolerated, with only mild to moderate treatment-related adverse events, and also not very many treatment discontinuations. So permanent discontinuation based on treatment-related adverse events was 15.7%. I just remember crizotinib is like 10% to 11%, so it doesn't really stick out very much. Dose reduction is simple. You just go from 2 tablets to 1 tablet. You can also, of course, dose interrupt and then re-challenge the patient with a reduced dose. Of course, tepotinib should be permanently discontinued in patients who are unable to tolerate the 1 tablet per day. Here you can see on the left-hand side the first-line patients with no dose reductions left hand here. And these are the patients with dose reductions. And this swimmer's plot actually tells you how long the patients actually got the medication. And you can see that without dose reduction, it was, if anything, even shorter than with dose reduction. And the patient without dose reduction with second-line patients and no dose reduction and with dose reduction. So dose reduction really leads to the fact that tepotinib can be given for a long period of time. So this is it. I was 3 minutes over the time. I hope that it was interesting for you, and I'm happy to share for the discussion, which we I think have after the next talk. Thank you.
Thank you so much, Professor, for that insightful talk. And now we'll move to the next part of our agenda, which is we will hear from Dr. Ajay Kumar Singh, sir, who's the Director and Head in the Medical and Hemato-Oncology Department at Paras Hospital in Kanpur. And he'll be taking us through some of his cases encompassing MET inhibitor, including TETMEDCO. Over to you, Dr. Ajay Singh, sir.
Thank you, ma'am. Thank you, ma'am, for organizing this event, and thank you, Sekhar, sir. So, good evening, everyone, and respected seniors and dear colleagues. So, today I'll be discussing regarding the interesting case. So, obviously, this is the first case who got the tepotinib in India, and I was privileged to get this medicine through the compassionate program when I was working in TMH Mumbai. So this lady who was 83-year-old, and she had some cough complaints for which she was evaluated at her home place, and she was found to have some one mass along with the bilateral ground glass opacities, which was looks like a disease. So she underwent a biopsy procedure, and that kit turned out to be adenocarcinoma lung, but the tissue was minimum. And then she came to TMH Mumbai for opinion. So she was 83 years. Other than cough, she was well preserved, but she was not keen on any kind of chemotherapy or immunotherapy. So she was requesting not to be aggressive. So we advised to go ahead for testing as per the guideline for biomolecular testing, and we were hoping she may turn out to be a common mutation positive like EGFR or maybe ALK, and for which the multiple drugs were available in India on regular basis. So the tissue was inadequate, so we did the liquid biopsy from the blood and with liquid NGS from the blood, and she was fortunately detected to have METex14 mutation. But unfortunate thing for our place was that we don't have any commercial available drug for escaping mutation. Capmatinib was there, but the compassionate program was stopped, so she was not able to access the capmatinib. And then the next was the tepotinib, and luckily that time the tepotinib access program was ongoing, compassionate access program, and we applied and we got. So she was started on the drug in 2021, and in next 3 months she had a good response. Her symptom cough was resolved, and radiologically also the ground glass opacities and has subsided, and the mass also significantly reduced. And subsequently we keep her on follow-up, and at 6 months, at 9 months, she had maintained partial means response was got even better with the at 6 and 9 months, and after that achieving almost near CR. She was remaining maintained response for more than 1.5 years when last I was working in TMH. The next slide, please. So, so after this case, so this is one of our case series which was presented from India. This was a real world evidence, And in this study, we collected the data from two prominent institutes from India. One is TMH Mumbai, and the other is the Rajiv Gandhi Cancer Institute from Delhi. In this, we analyzed the patients who got TKI either in first line or second line for MET exon skipping mutation in comparison to the standard chemotherapy. And primary endpoint was to analyze the our survival outcome like PFS and OS. Next slide, please. So, okay, so same slide. So here we had 14 patients in the MET exon 14 mutation and 28 patients in the chemotherapy arm. So in the patients, we can see that in the this is the PFS graph. And those patients who received the first line MET inhibitor had a significantly prolonged progression-free survival. It was almost double from 5.9 months to 11.9 months. Similarly, also in patients who got MET TKI inhibitor in the second line, again, PFS significantly improved, almost doubled from 4.5 months to 7.7 months. And again, in both, we can see that these differences are statistically beneficial with a significant p-value and more or less than 0.002 in the first line arm and in the less than 0.04 in the second line arm. Next slide, please. So these are the demographic data, and to show that multiple factors were analyzed, which factor will affect the outcome. So here you can see that the age, sex, smoking status has not affected the outcome, whether they have received TKI or this. Only factor which was shown significant association was the TP co-mutation with TP53. So other than those, there was some numerical difference for brain mets at presentation, but the significant association was seen was only with those patients who had MET skipping mutation along with the TP53. In this, the outcome was worsened as compared to those who had no co-mutation with TP53. Next slide, please. Next slide, please.
Can we please have the next slide, please?
So this is the our summary of this largest Indian study. So in this real world data is consistent with previously published phase 2 data which sir just showed. The first line TKI double the PFS in comparison to chemotherapy arm from around 5.5 months to around 12 months. The MET TKI showed higher systemic and intracranial efficacy, which is manageable with safety manageable safety profile. And the only negative point is that those patients who are having co-mutation with TP53, they are having a worse outcome even with the TKI exposure. So this study confirmed that MET inhibitors have no safety signal. Most common adverse events, as sir mentioned, was the troublesome was the peripheral edema. So even despite the adequate measures, the peripheral edema will trouble throughout the course of the therapy. So we need to be careful while monitoring the side effects with the interruption or dose reduction. And sometimes, sir, as sir said, we can start giving this prophylaxis before these symptoms appear. And majority of the adverse events were either grade 1 or grade 2, other than the period edema, and reversible with dose adjustments or interruptions. Next slide, please. So I think this was the last slide, and I hope this case study and the case series which was presented will be helpful to the Indian doctors. Thank you.
Thank you so much, Dr. Ajay sir, for sharing your clinical experience with MET inhibitors. Moving on to the final part of our agenda, which is the panel discussion. And for this, I would like to welcome Dr. T. Raja sir, who is Director of Medical Oncology at Apollo Hospitals in Chennai. And sir has more than 28 years of experience in cancer care. And he is a senior consultant in bone marrow transplantation. He has deep expertise in the lung cancer field, specializing in NSCLC. And Doctor, welcome, and we are truly honored to have you as a moderator. So we'll take it forward from here.
Thank you. Thank you, Juhi. Thank you for the introduction. And I sincerely thank Merck for putting us all together. And allow me to share my slides.
Sure.
Yes, sir.
Thank you. Hopefully visible well, audible.
Yes, yes. Please go ahead, sir.
Thank you. So, I mean, once again, thanks, Mark, for putting us all together. And I must thank Professor Graysinger for that eminent lecture. We really take away a lot of your insights from that. Thank you, Professor. And I'm privileged to again to introduce or welcome my panelist, Dr. Rajat Bajaj. You heard him, and he is from Noida, Delhi, and Dr. Ajay Kumar Singh. He is from Kanpur, and Dr. Deepak is from Jaipur. Dr. Priya is from Delhi, and Dr. Ravi Jaiswal is from Raipur. Basically, these are from different parts of our country, Professor Graysinger. So, I mean, you will be able to hear a wide range of experience, and they are all from different institutions, and each one of them are very busy doctors. So it will be nice to hear their insights on what do they think at this point.
Sir, only one thing. Sir, Dr. Rajat Bajaj, sir, is dropped out because some issue. So you can continue the rest of the panel. Everybody's here. Thanks.
Thank you. Thank you. So, I mean, the panel discussion, I mean, we heard Professor Graysinger about the incidence of oncogenic driver alterations, of course. I just want to listen to the Indian experience, if I may ask Dr. Ravi Jaiswal, if you are there. I'll begin with you.
Yes, I am here.
Hi, Ravi.
Yes.
What is your overall view on, I mean, what is the percentage of patients that you think will have this? What is your expectation? And then what exactly has been your experience?
So, if I see 50 patients of lung cancer, I would say 1 or 2 would have METex14 slice mutation in my practice. I'm talking about non-small cell lung cancer. So don't see very frequently, but then yes, I have till now I have treated 4 patients with this mutation, and all 4 with the same drug, tepotinib. I did not have the opportunity to use capmatinib in my practice.
We'll come to
Yes.
that.
Yeah.
We'll come to that. We're just quickly
Yeah.
looking at the incidents and what is everyone's experience. And if I may ask Dr. Deepak, what do you think is the incidence I mean, that you have seen, and what is that you have seen in your practice, Dr. Deepak?
So, sir, actually, I have seen very less Metexon in my practice. I am leading the lung cancer portfolio in my hospital, largest volume of patient, but somehow I think Metexon is coming out very less, although I get it tested by NGS for all patients. Another reason is that we have more of squamous cell carcinoma rather than adeno. So maybe that may be the reason that we are having less of Metexons. Very less, I think 2% or something.
Interesting. Okay. And Dr. Priya, I mean, you heard Professor Graysinger's presentation, and so if you are confronted with the option of doing a very small panel of, I mean, biomarker testing for non-small cell lung cancer for cost consideration, and then you have a necessity to not to miss these unique alterations, and then you're thinking about your NGS, which patient cohort would you be particular to try and get a broader testing, Dr. Priya?
Sir, see, sir, my understanding is that the labs that we order NGSs, they actually are capable of doing a broader panel, but because of the cost, they are just reporting a smaller panel. So, a smaller panel we are doing in all adenocarcinomas and in all non-smoker squamous cell carcinomas. That is what we are doing. And if
your smaller panel, does that include
MET? Yes, sir. It does.
Okay.
It does.
So
all possible actionable mutations are done in that.
Okay.
So we are.
Dr. Ajay, to you, the same question. Would you want to test it on your squamous cell carcinomas as well or not?
So, sir, actually, we are doing. Only concern for me is a small panel. I'm not sure whether they are doing RNA fusion. Most of the time, the small panel, and they are doing just DNA analysis. So there is a high possibility we will miss these fusion mutations. So I'm not very comfortable to do a smaller panel like 12 and 8, which are cost saving, but these are the tests which are having very less sensitivity, will miss the important informations. So nowadays, I think cost is down, substantially down. Even 50, 60 panel now we are able to get the NGS testing by 15,000 or 20,000. So I always counsel my patient to broader panel, which includes the RNA fusion testing as well.
Okay, I'll turn to Professor Greisinger. Professor, you heard the viewpoints from some of our eminent panelists. By smaller panel, what they mean is typically 12 to 14, biomarker testing. Usually, it's actually usually a hotspot mutation. That's what they mean by smaller panel testing. Some of the hospitals are again able to offer, hotspot testing on a slightly bigger panel. Some of them do 58, some of them do 168. But a typical sequencing, for example, I'm just saying a DNA sequencing by Foundation One or Guardant, that's considered to be slightly more expensive. So by broader testing, that's what we mean. Just to be simplistic on the testing methods. So the question to you is this: what will be the ideal option to
Come on
test?
in.
And because it is said that apart from DNA sequencing, one of them mentioned that even in a good lab, RNA sequencing is also important for picking up most of the METex14 or MET alterations. So based on that, what will be your comment, Professor?
So we're doing a pretty broad NGS test panel, which is DNA based. This is a hybrid capture NGS panel that actually detects all the METex14 skipping mutation. A lot of people say that METex14 skipping mutation sensitivity, detection sensitivity would be higher on RNA based methods. We're not really seeing that with the methods that we have. And we're testing all patients, so not only the squamous cell carcinomas that are non-smokers. We did that until about 5 years ago, and then came NTRK mutations, and we were aware that also squamous cell carcinomas had an incidence of about 6% for EGFR mutations, and so we then said, no, it's unethical to exclude the squamous cell carcinomas that have had smoked from testing. So we're basically now testing, or actually we are recommending that every patient with a non-small cell lung cancer, irrespective of histology and irrespective of smoking status, should be tested. Of course, this is not a reality. We have a test rate in our CRISP registry, which is a pretty broad register where we kind of reflect and include patients from a little bit specialized centers. We have a test rate in adenocarcinomas about between 80 and 90%, but in squamous cell carcinomas only about 60%. But it's getting up, and we had patients that had the histology of pure squamous cell carcinoma and that were METex14 skipping positive. It turned out later that this was a adenosquamous carcinoma. But sometimes you just, with these small biopsies, you just only detect one part of the coin, and therefore, yeah, we test broadly every non-small cell lung cancer patient.
Every non-small cell lung cancer patient. That's very eminently put. Thank you. So, but then coming down to your vision study, if you look at the distribution, about 80% of your patients were adenocarcinomas. Was that by design, that you were selecting your patients, or this is just as it happened? So your inclusion criteria, did it include all histologies, or was there a ratio of adeno versus? So I'm just asking about your inclusion criteria based on histology in vision study.
As far as I remember, because the vision study is a bit older, but all histologies were allowed. The problem is that you could include by, I mean, you could include by local testing that had to be then confirmed by central testing, either by liquid or by tissue biopsy. The problem, if you don't test the patient ahead of time, then of course you don't kind of try to get the patient into the trial. And definitely there's a bias for testing patients that have adenocarcinomas, for testing even female patients, for testing patients that are never smokers or light smokers. So I think the distribution of the histologies kind of reflects a little bit also what is being done in testing. So maybe nowadays, where we all recommend testing broadly, also in independent of histology, maybe the distribution would be a little bit higher for the squamous cell histologies. But at the time when the study was done, I think there was a clear bias for testing adenocarcinomas.
Perfect. Thank you. And now coming back to Dr. Ravi, I'm again starting with you. What do you look for when you want to look at MET alterations? I mean, now let's assume that you have a good panel done. So from that point of view, what do you look for? And when you are presented with these changes, what thoughts come to your mind?
So I think Professor made it very easy and clear in his presentation that exon 14 splicing mutation, that is what we would be looking at, and amplifications are not the ones which are going to benefit. So I think I'd look at exon 14 splicing mutations.
Okay. Dr. Priya, you don't even want to hear about amplifications? That's what Ravi has said. What do you want to say about that?
Want to hear about amplification? Yes, I would.
You would.
Yes.
You would. Okay. So then Deepak, what sort of results that you are looking for in
And we see also more amplification, sir, as the patient takes treatment, like, as a resistant pathways.
follow? Yeah.
Upfront amplifications are very rare.
Okay, so we are looking for splicing mutation only. But if patient is having high level of amplification also, then also I think we can consider for tepotinib.
Okay, we'll come to that. And Dr. Ajay, what is your comment on what sort of changes that you are looking for with the MET? And why is it important from your point of view, Dr. Ajay? Ajay, you are able to hear me?
Yes, sir. So, sir, as everyone saying, among these mutations, obviously skipping for 14 mutation is the most important, which has shown the greatest response. But I don't think even amplification and these, if it is there, maybe for in first line, I will not be keen to give targeted therapy. But in second line, especially after chemotherapy exposure or other these, when patients develop amplification, and if it is more than 6 or 10. I'll like to add MET inhibitors, whichever is available to tackle the resistance pathway. But in upfront, if there is amplification, I may not be very keen to add any MET inhibitors. I think this is my take, sir.
Okay. Thank you. So I'll turn to Professor Gressinger. Professor, I mean, of course, it's very obvious to say that we are all looking for the splicing mutation, as you clearly showed that beautiful cartoon that the intronic cut really takes away the 14 and the fusion happens. But what about amplifications? And let's cutting across the first line and second line. What is your thought about MET amplification and in the context of these drugs, Professor?
So, did you address me?
Yes, Professor Grace.
Okay, sorry. So, I mean, again, MET amplification is, of course, a matter of debate. I think the real impact on oncogenic transformation is still has to be really defined. There are different levels of amplification. There are also studies that are based on liquid biopsy, where different levels also of amplification then are determined. So I think that's a matter of debate. I think that's not yet ready for real, I mean, for prime time and for patient, I mean, outside of studies, I probably wouldn't do this. MET amplification, of course, plays a role when patients get resistant against OC, because they have about 30% MET amplification. And there it could be very helpful to treat those patients with an EGFR TKI plus a MET TKI. No. And then maybe one comment. Yeah, we're looking for MET exon 14 skipping mutation, of course, and but we're also looking for MET fusions, because we've seen some patients with MET fusion. I think our group even has the German group has even published a pretty small number of patients, and they respond to MET inhibitors. So if you ever find a MET fusion, then probably a MET inhibitor would also be helpful.
Excellent point. Thank you. Again, one very important point that Professor Graesinger pointed out is that if you are talking about amplification, actually it's not. Different studies have used different cutoff of what CNV will be the copy number variation is considered as the inclusion criteria. For example, if you go to geometry, it's 2.5. If you come to in some other trial, it's 5. So that's very important point that you pointed out when you want to practically consider. But again, in the context of a patient who is on an EGFR therapy, and even in any other, this becomes important. And the liquid biopsies are a very potent tool. That's what he pointed out. Dr. Priya, how comfortable you are in picking up your mutations in liquid biopsies, and you heard, Professor, that the pickup basically because of the ctDNA load. And he also pointed out the distribution of brain secondaries in patients who were detected by liquid biopsy or were found to be proportionately higher, basically talking about the tumor load or whatever. So your thoughts on liquid biopsy?
Sir, so that was actually a very interesting information from the vision study that Dr. Shared. So, right now we are doing solid tissue biopsy for all the lung cancer patients, isn't it? So that is the conventional practice, and we are doing it. It helps you to establish what is the kind of cancer, give you sample for DNAs also. It's only that if the patient is on the blood thinners or there is an inaccessible tissue site, or patient is unwilling for the tissue biopsy, we go only for the liquid biopsy. Otherwise, our practice is to do tissue biopsy, and sometimes there's an understanding that maybe you are missing on certain biopsies by not certain mutations by not doing the liquid biopsy part, so you do a complementary assay. But just doing the liquid biopsy is not the usual practice in our case. We will do it only in few situations. So as such, the standard as of now in my practice is to do a tissue biopsy plus minus liquid biopsy. So that is what our practice is.
Dr. Deepak, would that be your comment on liquid biopsies? Do you also think that?
Yeah, I agree with Dr. Priya. We usually do tissue biopsy whenever possible. But if tissue is not accessible, then only we go for liquid biopsy.
Okay. So, I mean, I'll just pick up one case scenario. This is mentioned here as, I believe this is a hypothetical scenario, because it's a 50-year-old female, which is very untypical of what we would expect in a MET exon 14. But she presents with cough and breathlessness and has got a PD-L1 of 80%, and an NGS done shows MET exon 14 skipping mutation. So sometimes or practically in many patients, you may be at a position to start chemotherapy until after you get the results from your NGS. So you got your NGS and it is clearly giving you a METex14 skipping mutation. So Ravi, would you be immediately dropping your chemotherapy and switching over? What will you do in real practice, Dr.
Yes. So, in my real practice, if let's say only one cycle of chemotherapy was administered to this patient and I have access to tepotinib, I would stop chemotherapy and start this patient on tepotinib tablet. That would what I would be doing.
Okay. So, Dr. Ajay, would you be doing the same thing, Dr. Ajay? Dr. Deepak?
Yeah, yes, sir. If patient is on chemotherapy started and NGS comes out to be exon 14 skipping mutation, then I will definitely stop chemotherapy because with chemotherapy outcomes are not so very good. So I will switch to tepotinib.
Okay. I'll come to Professor Graysinger on this. I think we heard a comment from him that this being a potent drug, the efficacy, the ORR is as good in the second line as compared to the first line. And then, of course, the Vision study fortunately has first line, second line patients. And so, is there a compelling urgency to completely drop the chemotherapy and switch, or are we justified in continuing, a few more cycles, achieving a partial response, and then look for evolution? What is your take, Professor? Because these are clonal, almost clonal mutations, so I don't think that will change. That's what I think. I don't know. I'll wait for your comment.
So I think that tepotinib has shown that it's almost as good in second line as in first line, but I mean, I showed you that there's slight differences, especially duration of response in first versus second line. And in most countries, actually, tepotinib has been licensed and approved for first line. Unfortunately, in Europe, not. So our approval is only in second line, although I think the data are pretty convincing that it should be actually done in first line. So if you have a patient that has been started on chemotherapy, which of course sometimes happens, or maybe chemo plus IO, then I would say that at least the real-world data, of course, the real-world data do not replace prospective randomized trial. We always have some difficulties, of course. So it's always an indirect comparison if you want. But I would basically also try to then switch the patient to tepotinib. We have a lot of patients actually that are like the patients that were included in the study that are age 80, 82, and although we only have an approval in second line, we're just saying to the health insurers, this patient cannot get chemotherapy or chemo IO. He's not amenable to that. So we start, although we only have approval in second line, we start with tepotinib first line.
Thank you.
So we would, as in most other oncogenic driver mutated non-small cell lung cancers, we would prefer the TKI over chemo or chemo IO or IO's monotherapy.
If I may ask you on a pure academic sense, Professor Graysinger, you mentioned that capmatinib has been withdrawn from Germany. I mean, without any bias, was that based on being efficient in the drug distribution? I mean, in the drug procurement, etc., logistic reason, or on toxicity basis? Can you tell us why was it withdrawn?
You know that in Germany, the price is, if you want, set for a lot of different countries. And I think it was really a matter of pricing. And therefore, they retracted it from Germany.
Sure.
So, Dr. Raja,
Dr. Priya, you have a question. Please go ahead.
Yes, see, sir, my concern is whenever the patient had disease in the liver, And if the disease progresses in the liver, giving any TKI becomes very challenging. So
So you
with
want to, yeah.
yes, so I think for me, because liver is such a vital organ for the metabolism of so many drugs. So I think there's always a chance that such patients, they might not be fit for a second line therapy, the ones with the liver mets. If that is the site of progression, I know that the patient can deteriorate very rapidly. So, you know,
That's
I think that's a very important comment that you're making,
yes,
because we're losing so many patients between first
yes,
and second line. So
yes.
that I also think that best thing first, because patients might never make it to second line.
also the CNS efficacy. So your point is taken, Dr. Priya. It was only to, put him on the spot to ask, why not? So, but of course, I completely
So,
take
it's
your.
very comfortable to know that the drug offers the similar amount of benefit in the first and the second line.
Oh, very true. Very, very true. Agreed with you. And once the availability becomes easier and cost considerations are always there. This is the data as was shown by, Dr. Ajay, the Indian data. That's very nice because this had 14 patients and 2:1 ratio on chemotherapy, 28 chemotherapy patients. That showed that the 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 original vision study could be replicated here, almost identical response rates in both the first line and second line. That's very comforting, and there were no new or unexpected safety signals. So that was also very comforting. So then coming back to our panelists, Dr. Deepak, if I have to turn to you, which MET inhibitor would you prefer? Now we have both the inhibitors, TKIs available in India. Just talking about TKI. Dr. Deepak, your choice. One word answer.
One word answer is Metco, sir, because I think that has better survival data and lesser toxicity profile as compared to capmatinib. And second thing is that I have not much experience of using capmatinib also.
Okay, fine. So one word answer, what he said probably represents everybody's view. So I'll move on. Professor, this matching adjusted indirect comparison, how relevant is this? This is never a direct science, but this is now increasingly being used, and particularly in non-small cell lung cancer, if you see, a lot of make discussion happens. So what should you are, you have been leading many investigations. You have been a principal investigator and you have a deep insight. So would you always take this for a conversion into clinical practice? What is your advice, Professor?
I mean, it's always a matter, of course, of getting. I'm sorry, I just have to. It's always a matter, of course, of really getting the precise data of the individual patient, so that you can really compare those patients. And that is sometimes, I mean, especially if you have two different companies that are sitting on their data, that might be difficult. And I think the patient selection, of course, is and the really the matching of the patient characteristics is key. In my understanding, and I looked very much on the capmatinib data, and also, of course, because we're involved in the tepotinib data, I would say that there is probably not much difference between the two drugs. The first line data look pretty similar, although tepotinib is a bit higher. The second line data, everybody knew that the second line data with capmatinib were much worse than the first line data, which is inconsistent to the concept of a TKI, because if you pre-treat a patient with chemo or with IO, then the overwhelming oncogenic driver inhibition should still work. So my view was always that there was some kind of weird negative patient selection. I would say that there's probably not much difference between tepotinib and capmatinib, and I mean, in Germany, we don't have to answer the question anymore because we only have one drug available. I have treated more patients with tepotinib, so I have much more experience with that. I only have treated very, very few patients with capmatinib, and having both drugs in hand, again, I wouldn't say that there is much difference.
Totally agreed, Professor. Ravi, you are happy with the intracranial efficacy of tepotinib?
Yes, sir. Very much happy with the intracranial efficacy of the drug and the data that is shown by Professor. I think this is what we want with a TKI, like we saw with osimertinib, lorlatinib. I think similarly the drug fits in, and would be very happy to use it in patients even if they have brain metastasis upfront as well.
Thank you for your comment. Dr. Priya, the adverse events, that becomes very important when particularly joining issue with the comment that once the first line, second line ideas and all that, but adverse events are a reality. And I mean, we have used it. I have used both the drugs, and I've used it. I mean, a few years ago, we have started using. Early on, we didn't have a complete understanding of how to manage these adverse events, and this was a novel drug, new drug, and the toxicity was also slightly different from the other TKIs. So it was initially a bit tough in handling, but then we settled down. So your comments on the toxicity profile and what have you learned to make it better for your patient?
Sir, so whenever we start a patient on TKI, we understand. So if you get a hang of using the drug again and again, you automatically get a hang of managing the side effects. So like we started with the EGFR TKIs, then ALK TKIs. So actually these drugs are tolerable. So in my practice, no patients have actually discontinued the drug because of side. If you explain the side effects, the edema is something that is bothersome. Nausea, not that much. And even hypoalbuminemia is not much of a clinically relevant toxicity. So I would say that I'm not much bothered about the toxicities, and so they are very much manageable with few simple advices, as doctor already showed in his presentation.
Okay, thank you.
Yes, we do get to hear the complaint, but I have not seen much fatigue in my practice. I have not seen much nausea in my practice. No.
Okay.
Dr. Raja, can I ask a question? I am Dr. Shekhar Patel.
Hi, Dr. Shekhar. Most welcome, please.
Yeah, just because we see about 70 to 80% of people get edema. I have also used quite a few patients. Yeah. Why can't we start with a lower dose? Start with only one tablet, and instead of a full dose, 50% of dose, because whether we can reduce without affecting the efficacy, that is the one question. Second, regarding when they showed that the T53 mutations are have got a poor response even with this TK, can't we combine with chemotherapy? Are there any studies available combining chemo with this tepotinib or capmatinib? Any ongoing studies or any experience of yours? That is, these are the two things just I wanted to have an input from you.
Yeah. Great questions. I don't even want to pretend I know the answer, but my sense is that you can drop the dose quickly on tepotinib. You can bring it down. That could be. But let's hear from Professor Greisinger is here, so we should use him to the best. We can hear his answers on this comment.
Comment on starting with a lower dose. Is that it?
Yeah.
Yeah. Actually, good idea, or at least an idea that should be maybe explored. I think we don't have any data, so formally I cannot recommend this, but we would have to generate data. If dose reduction doesn't affect the efficacy, why not start with a reduced dose? Sometimes I think we have learned that if you do a dose reduction based on AEs, then you don't lose efficacy. If you do a dose reduction without any AEs, just by dose reducing, then nobody really knows whether you might lose efficacy. So I think we would have to generate really data with a reduced dose. In terms of dose reduction and also pausing, especially in the management of edemas, I think we all should be aware that these measures only have kind of a moderate effect on edemas as side effects. So I think the primary prevention and preemptive measures are so important to really try to avoid edemas.
Absolutely. Absolutely. I can relate to that because early on when we started off, we ended up having significant edema. Even after I stopped and switched over to other lines, it really took many months for the patient to get better. That's why I said I could see the ferocity of the drug early on. So that's what I wanted to comment. So the second part of Professor Shekhar Patil's question is that are there studies that are ongoing in combos with the chemotherapy? That's what he pointed out. To the best of my knowledge, obviously, yes. The evolving field is that there are actually there are newer antibodies also evolving beyond amivantamab. Now there is a second generation antibody, and then even couple of drug conjugates are also coming. And to the question to you asked, now there are studies to combine a couple of molecules are on. So from that point of view, Professor Graysinger, the resistance mechanism once again of after MET targets is very interesting. There is evolution of KRAS after that, and there is evolution of BRAF after that. So how frequent would you do longitudinal monitoring, repeat liquid biopsies when the patient is on METex14 and MET inhibitors, so to say? And when such resistance evolves, what do you do? What are you doing? You have a long experience. Can you tell us?
So in all oncogenically driven cancers, we try to do a rebiopsy in order to find the resistant mechanism, especially also because sometimes you find resistant mechanism where you have a specific drug, and then one could use the combination. I mean, it's an off-label combination, of course, but normally our health insurers do reimburse that. And so we try to do that. We treated actually one patient with a resistant mutation by switching the patient from crizo to capmatinib. That was also a case that we published. Yes, I would say it should be done. I think it has a little bit also of an academic approach, of course, because there's not too much known about how to treat based on resistant mechanisms in METex14 skipping, but to have insight and to have data in understanding why tepotinib or capmatinib don't work anymore, I think that is very helpful and very valuable.
So, I want to open the discussion to the panelists. And first of all, I want to thank Merck for providing me this opportunity to moderate this very eminent panel. To do justice to the panel, I'm opening the discussion. Please ask any questions that's relevant. Professor is here. Please fire away and use the best out of him.
So I have one question. So, Professor Gissinger, what's your take on amivantamab plus chemotherapy in first line or after tepotinib failure?
Well, so the question is after tepotinib to use the Mariposa 2 regimen. Well, it's a good idea. I haven't used it. I don't have any data on that. I'm not sure whether there's any data, but it's of course it's something to consider. Amivantamab is a MET inhibitor. I think the it's probably a better EGFR inhibitor than a MET inhibitor because, I mean, the edemas with amivantamab are pretty moderate, but the EGFR associated toxicity is pretty heavy. So I don't know whether really a MET resistant mechanisms can really be overcome, but yeah, I mean, it's a way to explore. Yeah, definitely.
Thank you.
I have got a question that to Professor Grisinger. I had a patient who progressed, not progressed, who had a responding extremely well, and tepotinib, he had developed a grade 3, grade 4 edema. It was almost like a very elderly person, and so we had a discussion about the next line of either with chemo plus immuno. But patient was not willing for chemotherapy. So are there any data for shifting to capmatinib? Because there are some patients who can tolerate capmatinib, whether we can shift, because the patient is responding very well to the TKI. Are there any studies available in that direction?
I'm really sorry, but I couldn't understand the question. Could somebody rephrase the question again? I think the audio is a little bit kind of bumpy.
Yeah.
I'll do that, Professor. Dr. Shekhar Patil is asking that his patient is responding well to tepotinib, but has got an intractable edema. So he's wondering whether switching over to capmatinib and maintaining the efficacy, and is the
No.
edema better? So that.
No, I don't think so at all. I think both do make edemas, and maybe it is true that with tepotinib they come a little bit earlier, and with capmatinib a little later. But they're there with capmatinib, I can tell you that, and they're as difficult to treat as with tepotinib. So I wouldn't recommend a switch.
Dr. Frank, one. So in my practice, in our practice, so whenever a patient with metastatic cancer comes, where we do the routine liver function test, we look at the albumin levels. Now the thing is, all of these TKIs, most of these TKIs are highly plasma protein bound, isn't it? And in the metastatic cancers, we see an albumin level sometimes below 3.5. Now, because do you think that the low albumin level actually contributes to a higher toxicity, and maybe such patients should be started on a lower dose? And maybe because in the trials that such patients were given a lower dose, after the dose reduction, the free drug concentration was actually like equal. So after the lowering of the dose, so they were able to have the same amount of efficacy. Your thoughts on this? So because we don't actually look at the serum albumin while deciding the dose, but we have seen more toxicity in the patients, and that's true for the most of the TKIs, because most of them I think are because highly plasma protein bound. When most of them are actually like the albumin is the main molecule to which they bind in the.
So I think it's definitely worthwhile exploring that, and also to systematically generate data.
Yes.
There are two drugs where I start with a lower dose, and this is afatinib. No, actually three. This is afatinib because I mean in some uncommon mutation we still use it, and not osimertinib, but afatinib, and there we have a lot of experience that that especially if you have a lot of side effects in the beginning. That then you might obviate these side effects by starting with a lower dose, and then after 4 weeks, if it's well tolerated, you then increase the dose. With lorlatinib, we do know this is a wonderful drug, but they have side effects. The side effects start especially during the first 4 weeks. So a little bit more frail patients, I start actually not with 100 milligrams, but with 50 milligrams, and also with soto. So sotorasib, I mean, there's a lot of discussion, what dose do you really need? Is 8 tablets really the right dose, or maybe you can get along with just 1 tablet? I always start with only a fourth of the dose, because I mean, there's some indication that it's probably as good as the full dose, but the full dose, of course, is much more more toxic. So we don't have any data with tepotinib. I mean, it's kind of from all that I've said. I mean, why not try it? The problem, of course, is that the side effects start later, and therefore it would then be most likely more permanent dose reduction, and you don't really know whether the patient would have had side effects on the full dose. So I'm a little bit hesitant to really recommend this without having any data. But it would be worthwhile to explore that in a study.
So the reason I ask is this, because I had a patient who had a nephrotic range proteinuria because of the bevacizumab and chemotherapy. Then subsequently we put him on efatinib. And at that time when we started him on efatinib, we just started on 20 milligram and his serum albumin was 1.9 and he had severe diarrhea. So, and because all these molecules, they have a very high protein binding. So maybe that's the reason.
I mean, we also have some data with afatinib, suggesting at least if you have to dose reduce, then it's because these patients have a bioavailability of the drug that is higher than the ones that don't have any dose reduction. And also with lorlatinib, we have some data to suggest that if you do a dose reduction based on AEs, then they fare as good as the ones that didn't have a dose reduction. So you have to decide it in the clinic, yeah. I mean, I think it's very difficult to give any formal recommendation. You're all doctors, you all have experience, and it's also a difference to work in Germany, where a lot of times it's cold, versus in India, where you probably have much high temperatures. So, for example, stockings, compression stockings. I mean, I cannot even imagine how somebody at 40 degrees can wear compression stockings. So, I mean, I think everybody has to kind of deal a little bit with practical issues. Yeah.
Thank you, Professor Gishinger. So, can we conclude things because the time is? I
Yes,
think
sir.
we overshooted the time. I think to conclude, I would just say that basically what we have learned today is that for all patients of lung cancer, whether it is a squamous or adenocarcinoma, all non-small cell cancers, lung cancer should undergo a proper broad spectrum of genomic studies to be done, so that we will not miss out any specific mutations like exon skipping mutation, because we have got a lot of drugs available for each and every mutations. As you've seen that with chemotherapy, if you have got a exon skip mutation, just with chemotherapy would have median PFS around 4 or 5 months. But if you identify that mutation and you give a proper drug, a person can survive for 1 to 2 years. So it makes a lot of difference in each individual. So it is very important. The testing is the first part. And second is, we have got a drug and we have to use optimally and with proper dosage, as Professor Gishinger has suggested, and monitor it and reduce the dose or modify the dose depending on the toxicities, and take preemptive measures so that we can prevent the toxicities to occur, so that they can receive the drug for a longer period of time. So by doing all these things, we will be improving the quality of life of our patient and getting a longer survival. With this few words, once again I thank Professor Gishinger for his nice talk, and Professor T. Raja for a nice moderation and educating us so nicely about all the issues which we day-to-day encounter. And thanks to Merck for giving this opportunity. Thank you. And I'll conclude with this one and hand over to Merck for final word.
Thank you so much, Dr. Shekhar Patil. Sir, I completely echo your thoughts and a great discussion. I think it will be of high value to everyone listening to the discussion. So thank you, everyone. Yes, we would like to conclude here. Thank you for your time, contribution, and valuable insights. And yes, have a good evening.
Thank you. Good night, everybody.
Bye.
Thank you very much. Bye-bye. Have a good